And in 2009, the foundation was awarded a cooperative agreement that assists designated countries in scaling up public-private partnerships. And the cooperative agreement is funded by the President's Emergency Plan for AIDS Relief, PEPFAR. And in this role, the CDC Foundation strives to value leveraging multi-sector investments in Kenya and Tanzania that support their mHealth initiatives. There are other programs under the cooperative agreement that are also aimed at increasing capacity, building capacity in countries, but they're not mobile health. So our largest programs in the cooperative agreement are our mobile health projects. And as a result, the CDC Foundation, and through the Foundation and our partners' efforts, Tanzania and Kenya are implementing a broad range of mobile health projects. They're very different in each country, and they are determined by the priorities of the Ministry of Health in each country. And the programs are all at various stages of implementation. So today the purpose of the presentation is for each of the panel participants to provide just a few key ideas from their agency's perspective regarding sustainability and country ownership of their mHealth projects. And their comments are going to be brief so that we'll have plenty of time for discussion, comments and questions afterwards. And each person will present just consecutively for about 10 minutes, and then at the end we'll have comments and questions. So I'm going to go ahead and introduce all of our guests, and they will then tell you who they are as they stand up. This is Dr. Esther Agara. She is with the Ministry of Health in Kenya. She's the head of the eHealth and Continuing Professional Development at the Ministry of Health. Welcome.
Thank you.
And the next Ministry of Health representative is, Mr. Josibert Rabono. And Mr. Rabono is the Assistant Director for Monitoring and Evaluation, and he's the head of the Health Sector Resource Secretariat, the Ministry of Health and Social Welfare in Tanzania. Welcome. And the next participant is a non-governmental partner of CDC in-country Kenya officer, James Quach. And James is the technical advisor on health information systems at CDC Kenya, and he's the technical advisor on the mHealth projects in Kenya. Welcome, James. And then the next two participants are the CDC Foundation country managers, and Dr. Kathy Mwangi is the mHealth Kenya country manager, and we're happy to have you. Welcome, Kathy. And then finally, Sarah Emerson is the CDC Foundation country manager in Tanzania. So we'll go ahead and get started, and welcome, and looking forward to our discussion. They do, yes.
Good morning. Good morning to you all. I know it's so early, but we are really grateful that those who have woken up to be with us, to listen to us, we are grateful to you. As Linda said, I represent the Ministry of Health, Kenya, and the first slide is basically showing where I come from. Where is that? We don't have it, okay. Excuse me, we don't have the remote for moving these things. Sorry for that. We don't have it. Okay, it's okay. Yeah, thank you. Yeah, thank you very much. So basically, I'm going to talk about sustainability. As government, we work with many partners, and there are lots of projects going on, but sometimes sustaining it is a problem. So I think that is why we are here. I'll dive quickly to the, how eHealth started in Kenya. In 2005, the World Health Assembly in Geneva had a very specific agenda on eHealth. And countries, member countries of WHO were requested actually to look into, taking eHealth as a strategy in providing health services. And that is when we picked it. We started developing the strategy. We have the strategy already. And the Ministry of Health has made significant strides. Why? Because in 2011, we actually launched the strategy. And this is serving as a blueprint for, any e-health activity or program in the country. The e-health concept has been embraced by the government, because if the government does not buy into it, then you don't move. Then we also have it is enshrined in the Vision 2030 in Kenya. The Kenya Vision 2030 is basically a document also going to guide Kenya in bringing up, its citizens to middle income, country. And we are working very hard on that. Just the other day, the president actually launched the first train from Syokimau to town. So we feel we are moving. Then it aims at providing easier access to healthcare to the population. And you know that in most developing countries, Kenya being one of them, most of our health facilities are sparsely distributed. And so e-health comes in very timely. Now, I want to dive quickly into the critical factors for sustainability. And we are talking of effective governance and leadership. Yes, we bring the project, but if there is no effective governance, effective leadership, then we cannot move. There must be resource availability, okay? Then training of critical mass of people. Yeah, e-health is a new concept. We've embraced it, but the professionals, are they aware? So we actually need to work with the professionals to take up any project on e-health and mHealth. Then we need to have astute networks. At the moment, there are many e-health or mHealth. Let me concentrate on mHealth because that is the topic for today. We have many mHealth activities going on. Like in Kenya, we have even mNursing. We are using mHealth, to train our nurses. And it's something which was launched the other day. And all these are going over the place, but we have to have network. There must be some knowledge management, based on the networks, existing networks. Then policy guidelines, yes, we have it because the government has the ICT policy, and that is where we actually linked up to develop the e-health strategy. We need legal framework. You all know that if we are going to implement some of these, then the issue of confidentiality comes in. Okay, so there must be some legal framework guiding this. Standards must be there. I've spoken about the strategy. And in Kenya now we have a new constitution. The new constitution now is, we are having about 47 counties. And so if we are taking up some of these, projects, then the counties must be able to take on these projects because they are the implementers. Now, critical factors continues, and we are talking about strategic approach at all levels of healthcare. We need to build sustainability component into all projects, identifying of key steps. And which are these key steps? Right here I've put them. Establishing sustainability drivers and strategies, very critical. Then we need to engage the government early enough to prepare for the uptake of ownership. Quite often what is happening is that Lots of projects are going on, but sometimes the government is not aware. So now we are ambushed. But if we plan it very well, then the government can even allocate some resources for those projects going on. There must be broad exploration of ideas and partners. Stakeholders analysis, structured analysis, very critical. Because if we know that this is what the stakeholders need, then the government, can do what it takes for the projects to move on smoothly. Another important, point is client responsiveness. How many of us care about the client when we are developing all these projects? So these are very, very critical. Then strategic management, capacity building and support. All this must be there, because if they are not there, the projects cannot move on. We need broad, open internal communication strategy within the government, because some projects comes in, and sometimes when we don't educate the government, they don't pick it up. So we need all these. Then stakeholders ownership, the community are very critical, because they are the recipient. So if they also know about it, then we say, look, can we cost share? The community can also take up some of these projects. Then we are talking about leveraging and harnessing corporate social responsibilities. In Kenya, this is happening. We have the telcos like Safaricom, annual basis. They are in the communities providing health care. And they can add value to what the government is doing. We also have a Standard Chartered Bank. One of the activities they usually take is on annual basis, they do, marathon. So in this marathon, they are collecting money to help avert blindness. So all these, if we can really harness these, then they are resources. Proper business planning and costing and implementation for long-term sustainability. These are all very critical. Now I'm going to conclude, because we need here to discuss. Yes, I've put my ideas, but we know that even amongst you, you have better ideas. And we need some of these ideas to beef up what we are doing. So, in conclusion, I'm saying these aforementioned issues on sustainability are derived from my own personal experience as the initiator and the head of eHealth in Kenya. Over the years, as you interact and you work, you gain certain experience. And these are some of the experiences I'm sharing. The scope includes successes, challenges, direct constraints, and vision for way forward. They are subject to additional discourse for prioritization. We actually need to prioritize some of these. And it is extremely important to break the ice between the eHealth practitioners and leadership. I've mentioned it, but if projects are to move on, then that's what we have to do. The key message here is that there are many opportunities even for the private sector to work with the government. And some of them I've already mentioned, like the telcos, the banks. And, we can work together in building and developing sustainable health systems. Because at the end of the day, even the mHealth projects, everything, we want systems. Because when we don't have the systems, then we are working in vain. So I want to sincerely acknowledge Kenya government and the line ministries, IFC, CDC Kenya for supporting my trip, CDC Foundation for working with us on certain things, and we are still going to work, Linda, because we see you have so much to offer. And the one thing I like about CDC is that they work with the government to tell them this is what we want to do. And we intermingle, and that encourages us actually to work together. And then Rockefeller, they really played a major role in actually developing the strategy. And DFID and GSMA. Thank you very much for listening to me. I'm grateful. Bye-bye.
Let me take this opportunity, first of all, to thank the organizers, specifically the CDC, for giving this opportunity so that we can share our views, the way we are approaching towards the developing the partnership between the public sector as well as private sector. For those who have come late, I'm Mr. Joseph Tirbona. I work with the Minister of Health in Tanzania in the Directorate of Policy and Planning. The subject which I wanted to share with you, if you are given the opportunity to make a presentation coming from the third world country, it is very challenging when you are talking about this sustainability. I'm saying so because Tanzania, my country, is still in the least developed countries, whereby 35 to 40% of our budget depend on the donors. And the services which is provided, which is supposed to actually be provided by the government, 40% of it is provided by the private sector. Now, if I take you back historically, when we gained our independence, our economy was really public. And for those who know Tanzania, there was a lot of nationalization, banking system. So for many years, our economy was managed by the public. But as we went on, I think we faced some challenges that the government alone cannot manage to sustain, either the budget system, whatever. So I think we come up with a long-term policy to try to address the kind of the problems we were facing. The first one which we came up with is the 2025 national vision. It is where the private sector was factored in order to have special roles. And as I'm talking, 20 years now back, it is when now we started to address, some of the activities which used to be done by the government were taken over by the private sector. Some of the parastatals, and this process is still going on. And I've started on the broad perspective that the issue, the Vision 2025, basically is targeting to transform our country from a lower income to middle income. And I think the basic things, if we want to sustain, you have to make sure that you have a sustainable economy. So I think that is where we start. Other issues will follow. So my presentation, basically, I will try to talk a bit about the strategies which we have, opportunities, challenges, and some lessons which we so far we have learned in the partnership with the government and the private. As I said, on the ground here, we have this vision. This is a long-term plan for the government, the way we needed to integrate and involve private in order to transform our economy. But again, we have, which related to that, we have a strategy for economic development and poverty reduction. Now we are in the phase 2, which we are going to implement it. Where we started implementing from 2011 up to 2015. But this is really related to our vision. But again, we have a policy on ICT. we cannot transform our economy. We have already realized that the ICT has got a basic contribution. Then if I go to downwards, we have our health policy. And the health policy, there is a statement which states that the importance of ICT in transforming our health to the better one. Then the translation of our health policy as well as our vision, we have a health sector strategic plan 3. Under health sector plan 3, we have a specific strategy on the public-private partnership. I think in our government sector, all ministries, departments have been asked that to establish a desk for public-private partnership. And as I am talking, we are now developing a strategy of public-private partnership, whereby I think we have already even one of our development partners was able to provide a consultant. So there is that strategy in order to the health, because the importance of private is very, very important. Under the health sector strategic plan 3, as I said, we have a strategy. It's a complete strategy on monitoring and evaluation. Under monitoring and evaluation is where you find the activity of mHealth have been coordinated. We have 5 years operation plan for monitoring and evaluation initiative, and we have 8 packages, and one of the package is about ICT and mHealth. So we have a 5-year full plan to develop the ICT as well as mHealth. But again, as I said, monitoring and evaluation is part of health system strengthening. I mean, in totality, we have, in order to sustain, there are some systems which we need to develop, like healthcare financing. I mean, as I said, we still have some problems in financing some of the health services in our country. So we have come up with the alternative mechanism in order, in the long run, so that we can sustain it. And one of it is health insurance. And we have a community health fund, because most of our population are in the rural. When we're talking about the health insurance, basically it is covering the civil servant, military forces and stuff. But what about the rurals, where the population, big population reside? So the mechanism there is to come up with the healthy community fund. But basically what we are targeting is to sustain health services at all levels, including even the issue of mHealth. So when you go to the rurals where there's some more problematic, which is a rural area is a more problematic area, we are anticipating that, you know, in our budget plan system, we are decentralizing our health services to the community level. So I think that at that level, people, they will be able to only to plan, and with the prepared funding mechanism, there will be some revenue which will be accrued so that they can sustain whatever they will be doing as related to health. Now, what kind of the opportunities we have in order to sustain this partnership? What is clearly from on our side that we have a clear policies and the strategies on public-private partnership. And another opportunity is that the private sector is very good in promoting productivity, efficiency, accountability, and the social marketing. One of the examples of the social marketing which we have applied this one is the area of combating malaria, where I think at one time we'll have to distribute these treated nets, and they will use the social marketing. They are very good, and actually we are now seeing some values. Now I think we are seeing that the malaria cases are going down. As I said, we have a good progress in strengthening prepaid scheme like health insurance and health community funds and so forth. But again, another opportunity is that we have SWAP, sector-wide approach. So time is not on my side, but again, we have some few challenges. We are still having some problems to encourage the private partners to work in rural areas, but with the prepaid scheme, we hope that they will be able to be attracted. Still, you have misinterpretation between the partnership. Actually, the most of the partners, especially private, they think that is just to get money from the government toward the private. But I think partnership, we have to work together and share the available resources. So, and another challenge is that there is the issue of equity. Under the private public partnership, you need to be careful when you want to have equitable health services. So I think that is where the government role comes in, because if you have partners who is concentrated in the urban, so what about the rural? Now it is where the government, until you reach a stage, you encourage the private to go to the rurals, to go to the rural areas. That is how you can address this such a problem. We have some few lessons. We learned that there is a willingness by private sector to engage with the government and to follow government leadership. We have enabling policies, plans, regulatory and the institutional arrangement, which need participation of the private sector at all levels. I mean, another thing that the government leadership and the coordination is very important. And again, what is another important is that the role of private sector need to be recognized and acknowledged, maybe with a few initial lists. Thank you for your attention.
Thank you. Good morning, ladies and gentlemen. I will try my very best to keep mine a little bit short. For one reason, the next two presentations are going to be from implementers, actual implementers. And for the other reason that we are all very interested in having sufficient time for discussions. So my name's James Kwach. I work for CDC in Kenya as the Health Information Systems Technical Advisor. I feel quite privileged to be here right now because CDC as a donor has certain interests. CDC Foundation has a cooperative agreement that is now in its 4th year out of 5 in implementing these mHealth projects. So I think this being like the second round lap of this cooperative agreement, at this point in time, there is acute donor interest in finding out how effective the projects have been, how successful the projects have been. And one area of measuring, one big area of measuring success is in its sustainability. So there is, therefore, from the 4th year out of 5, and given that just now, around now is when most of the projects are being launched, it is evident and it is obvious that the environment that we are in here has its challenges. So there is a very, very long list of challenges that are within seeing as to how public-private partnerships are successful or otherwise. Matter of fact, as from a CDC perspective, PPP projects, if you may, are at this point in time experimental. The interest is very acute in seeing how successful these are. There aren't many PPP. There are PPPs in other areas like laboratory and so on and so forth, but I think for mHealth, this is the only one that I know. So interest in success and sustainability, therefore, is very, very, very important. That said, I will not dwell much into the challenges, but I'd only like to highlight a few from a perspective of lessons learned, probably three to four challenges within sustainability of PPP projects. The very first one that Kenya we've experienced on is, in as much as you could try to make each case unique, I think generally it is next to impossible to run projects without being actually there. So I'm talking about local presence. So when you want to talk about sustainability or any aspect of success, then you have to be there. Now, it might not be obvious, but you all know that traditionally there's quite a number of projects that are run remotely. Now, the point and the lesson learned is that you cannot run such projects successfully or sustainably if you yourself, you're not really on the ground. When this project started off, that was the situation, but we had to make effort to make sure that there's people on the ground who are making sure that everything that's supposed to happen is happening. The second thing I'd like to highlight as a challenge is many a times a donor or an implementing partner will set off saying, we know what needs to be done. But if you're talking about the ownership, what you think you know needs to be done is probably not a priority to, say, the government. So the better approach is to actually approach the government, who actually represents the public, and have them say what needs to be done. I'm sure some of you or most of you have given your kids or a kid presents, and the next time you're taking garbage out, you're seeing that present going out in the garbage. And it's because what you thought was the best present for the kid was not really what they wanted. Probably you're giving the present because as a child you didn't have that present. So you think this should be cool for my kid. But, and I'm not equating government to kids, but the government is responsible for the public. And therefore its interests is the public interest, and they know best. So we had to change course. That's one of the reasons why we are in the 4th year at this stage. We had to change course somewhere along the way and say, hey, wait a minute, let's do what the government wants. The third lesson learned is, within the environment of working with the private sector, the public sector, and the public-private sectors, is that each case is really unique. You can't really come out with a one-size-fits-all solution. In fact, at all levels, from the government to individuals that occupy government offices, there is peculiarities, there is uniqueness. And so you'll be applying solutions towards success in different ways by assessing what's there. So you cannot come in with things written and cast on stone and then go in and hope that the solution will suit the office that you're working with. And then finally, I'd just like for all of us to recognize that mHealth by itself is special. For my work, mHealth is just one of the components. We take health information systems in general. But I usually like to look at the M as a conduit, as a vehicle in supporting every other thing that you do in HIS. Now what happens therefore in it being special is that there are very many players who are interested in this. the field called M. The moment you start talking about early infant diagnostics, you'll find like multiple players working on the same systems. So coordination in terms of sustainability is very important. And the government is best placed because it is central. There are many donors, many implementing partners in mHealth, but supporting the government to coordinate all of these efforts is another challenge or lesson learned. So I think I'm just going to stop there because I'm sure a lot more is going to be said by the presenters to come. And I'm also very keen in hearing other experiences and any Q&As. Thank you very much.
Good morning. My name is Dr. Kathy Mwangi, and I am going to use one of our projects as a case study. And I'll start with a scenario. So you have this healthcare worker in a very remote facility who needs some medical supplies. And what she does is she fills out a form, an order form, and sends it to the district hospital. And remember, the district hospital could be a couple kilometers away, but could take hours to get there because of the infrastructure. And once the order gets to the district hospital, they have to wait to get enough orders and a lot of other things to then take to the provincial hospital. And the provincial officer has to wait for other orders from other district hospitals before they send them to Nairobi. When they get to Nairobi, which could have taken a week or so, the mail has to be opened and identified for the Kenya Medical Supply Agency, and then it is sent to the Kenya Medical Supply Agency. By that time, it's 2 weeks later. Now, with the Kenya Medical Supply Agency, they decide, okay, we are going to fill this order that we received, but they have standard orders. It's the same HIV drugs, the same malaria drugs that are sent to all the other facilities all over the country. So maybe a month later, the healthcare worker receives more malaria drugs than they need, receives less HIV drugs, and receives no gloves, which they already ordered. Now, that has been the situation in our country over and over in many facilities in the very, very rural areas in Kenya. Now, we do know that when it comes to internet and infrastructure, there are challenges, but we also know that Kenya has succeeded when it comes to M-Pesa because a lot of people have mobile phones. So what happens is that was a gap that was identified by the Ministry of Health, and CDC Foundation then took up that gap and decided to work on it. So we identified a developer through a very competitive bid, and once we identified the developer who was going to develop the mobile application, we also had conditions that they had to be a part and parcel of this project. They had to provide some in-kind contribution. It had to be an open source system, because ultimately we want a system that the Ministry of Health can take up and keep moving with it, that it's a sustainable system. So we were very lucky. This one developer, a Kenyan-owned company, in-kind contribution, we got $66,000. They trained 2 staff for the Kenya Medical Supply Agency, and these 2 staff were part and parcel of the development of this system. So they understood the back end and the front end of this system, so that eventually, even after the private developer pulls away, there are staff within the ministry that understood the system and could continue working with this system. This same developer also were part and parcel of the national rollout. They are in the field working with the ministry, rolling out these projects and getting to understand what the challenges are in the field. In addition to this, we had to engage a mobile network provider who is Safaricom. Now, with Safaricom, we got very subsidized costs for data and SMS. And the other thing that we needed was to be able to purchase bulk airtime for the Ministry of Health. Because remember, when we go to the government is not always ready for technology. So we needed to be able to support them up till the time they will be ready. And we needed to work with them and, come up with a business plan so that maybe in a year or 2 years, by the time they take up this project, we can pull away and know that they were ready for it. So Safaricom was able to talk to the Communication Commission of Kenya, who provides the short codes. Kenya Medical Supply Agency needed 2 short codes, one that was going to be used internally by their staff and one that was going to be used by the public, because the public needed to inquire into their system. Now, we bought bulk airtime that was going to allow the Kenya Medical Supply Agency staff to actually send data using their phone for free. So we didn't have to buy phones for the employees because they could use their phones, and they didn't have to be smartphones because of the technology we used, the same technology that M-Pesa uses. And we were also able to get waivers so that the registration costs for the short codes were free. And then there is also a monthly fee that was also waived. So we do not have to pay for the monthly fees for those short codes. Now, the mobile system that was developed allows for KEMSA to order, or anybody within the country that has a mobile phone, to order their supplies. They are able to report expirations on their supplies. They are able to report stockouts, and they can have facility-to-facility communication. If you know that it's going to take a while before you receive your orders, you can communicate with the facilities around you and see if they may have some of the drugs you do not have. Donors have been able to support KEMSA. In addition to CDC Foundation supporting the mobile application, there were other donors that supported the logistics management information system. There were other donors that supported their enterprise resource, resource planning, the ERP. And eventually we would have one system that was going to support KEMSA, and there is still obviously a need for a data center for them. Now, when we think about sustainability, this really is a case study, but we are very optimistic because KEMSA is willing and has come up with a plan, so they know that in about a year they will be ready to inherit this. And even when the donors pull out, KEMSA will be able to have a budget, to set up a budget to support to pay these 2 employees that were trained by the developer. And they will be able to purchase any bulk airtime if it runs out. But this is the beauty of it. The inquiry system, the public inquiry system, when you send an SMS or an inquiry into the KEMSA system, you are charged a shilling by Safaricom. But we are able to charge a little more. So if you charge 3 shillings for the SMS printer, the 2 shillings that is extra out of the 3 shillings that Safaricom makes goes back into KEMSA. So there's a revenue sharing plan. So these 2 shillings goes back into the bulk airtime, and KEMSA does not have to keep buying bulk over and over. So these 2 shillings could keep supporting the bulk airtime. The other thing is that Safaricom wants people to keep using their system. They want people to continue inquiring into this system. So they advertise. And if they advertise for people to use KEMSA staff, the more people inquire into the system, the more money you make, the more money we have to add on into the bulk airtime. So we have KEMSA taking ownership of the system. We have Safaricom engaging and being a part of this project right from the beginning, working on behalf of KEMSA by communicating with the Communication Commission of Kenya. And then we have the developers who are engaging and being out there, getting dirty with the Ministry of Health. And it is still very early to say whether this is going to be a success or not. But I'm sure in a couple of months, in about a year, we will be able to share the successes of this. It's a case study. We are excited about it. As we all know, PPP is still a very new animal in many countries in the world. But that has been a business model that we worked on, and hopefully one of these days we get to share how successful it has been. Thank you.
We're ready now.
The names don't match up, so don't look at that.
Sorry? Okay. Good morning, ladies and gentlemen. How are you? All right. And for my Tanzanian colleagues, Habar za Sabui, how was the morning? I hope that you all are doing well. I will go ahead and first like to recognize my esteemed colleagues from the Ministry of Health and Social Welfare from Tanzania. We have three honorable guests here from the Ministry of Health, Dr. Mwendo Manesi, who is the National mHealth Coordinator, and to her left is Dr. Winani, who is the National Coordinator of the Safe Motherhood Initiative, and Linda has already introduced Mr. Rabona, who is Acting Director of the Department of Policy and Planning at the Ministry of Health. Again, it's really my privilege and honor to be able to stand in front of you as the country manager for the public-private partnership, but really this is a ministry co-led program. So again, I would just like to acknowledge the work of my colleagues and that I have the opportunity to represent them today. So thank you for that privilege. I'm going to try to be very brief. And those of you who have been in the scale-up meeting, you'll see that there's some central themes that I believe are in common with scaling and sustainability. I'll highlight some of the opportunities and challenges. I can't really see this very well. That's okay. No problem. As well as go through, yeah, I can't see that. Try to get comfortable, save you all the next 2 minutes of my presentation, and go through some examples specifically from Tanzania. As I mentioned, this is a Ministry of Health co-led PPP. The ministry in particular is reaching out to underserved communities, and one of the key strategies for that is in utilizing the mobile health. The CDC Foundation contractor with is managing this public-private partnership on behalf of the Ministry of Health and the U.S. Government Centers for Disease Control and Prevention. Our focus really is in building multiple partner PPPs. We do believe that the more partners you can get involved, you do minimize risk. If one partner, for example, does lose funding, does pull out, changes business strategy. So we are focused on building multi-partnerships. Again, there are some trade-offs with this in that they tend to take a lot of time to develop, but this is a key principle and focus of our PPPs. Our partnership objective clearly is in leveraging the booming mobile infrastructure in Tanzania, which remains the best infrastructure in the country. Focus on increasing evidence-based planning, decision-making, and public awareness. Now, I'll just move quickly and put out a few themes and concepts. Again, I think my colleagues have already done an excellent job on the panel in highlighting many of these, so I'll be very brief. There's a question of priorities. Whose priorities are you working on in a country? I think there are often a number of competing priorities and demands, and I think in order for a program to be sustainable, there's the importance of starting out, as Mr. Rabona highlighted, in having it country-led and ensuring that you're following the ministry's priorities, the government's priorities. I think it was highlighted by several panelists, including James and Dr. O'Gara, that the government will know what its citizens' needs are, and that as folks are designing programs and thinking about funding opportunities or multi-year global health interventions, it is key to work with the government from the beginning, empowering them as they will have the understanding of what their public health priorities are. Again, really this helps facilitate the country ownership and leadership. Looking towards long-term strategy from the beginning. I'll just highlight a few different opportunities related to this specifically. Again, colleagues have talked about the idea of working with the regulatory communications authorities. An example, what we've done with Dr. Wanani's leadership, Dr. Mwendwa and Mr. Abona's leadership in the ministry with the Wazazi ni Pendeni free SMS service for pregnant women, is build maximum volumes to prove to the telecommunications companies that volume can be achieved in mobile health. We recently launched, I guess 15 days ago, a national mHealth free pregnancy SMS service for pregnant women, supporters, partners, information seekers. In 15 days, we have 24,000 registrants. So there is extreme interest. There's demand for this information. But what we are hoping, and this is the long-term strategy, is to demonstrate there can be volumes and go back to the Tanzania Regulatory Communications Authority to bring down and hopefully get a very, very low commercial rate for all mHealth projects, not just the Wazazi ni Pendeni. I think another long-term strategy requirement is really to look at total cost of ownership from the beginning. There are a lot of debates that one can get in around if you should have a customized off-the-shelf and open source, etc. I think they're all very relevant, and depending on the circumstance, they can be equally applicable and efficient. But it's just important to go in and have long-term conversations about what are the long-term costs, including retraining the staff, having system administrators, etc. Again, there's the idea that there are often a lot of hidden costs, and it's important to be upfront. Partnerships. Here's a few ideas about what it takes to have successful, sustainable partnerships. I think number one is coming to the table and really understanding who you're working with. And I know that the room isn't full today, but to me, it feels crowded, because obviously the elephant in the room is who pays for what. And I think Kathy did an excellent job of highlighting an example with KEMSA, of Safaricom being able to generate income. But I think it's a key part, and in particular, if you're going to work with the private sector, you do need to look at, here we go, making money. Again, so I think it's important to draw out and acknowledge on the theme of knowing who you're working with. And if we are talking about engaging with private sector, then they do need to be profitable. So I think I'll go back quickly to this slide and just summarize in brief on a few opportunities funding-wise. There's the idea, I think, that Mr. Abona highlighted around the government paying just a straight, fee-for-service, where there is sufficient, GDP that's being generated and the government can sustain and pay for out-of-fee services. There are a variety of different types of public-private partnerships that can be discussed, including revenue-sharing models where consumers are charged and money can go back into the government. I'd really like to encourage more dialogue in the sustainable financing around the bundling of mHealth with mobile money so that we can take some of the pressure off from, let's say, this free SMS service being profitable. Why not, as Kathy said, look at the value-added services, look at premium services, and put some of the pressure back on the private sector telecommunications to then upsell. We can bring people in, and then they can sell. I'll give an example of the incentives, what's in it for the private sector. The example with the Wazazi ni Pendeni campaign. Just in the next 6 months alone, there are 28,000 radio ads that will be run in Tanzania promoting the SMS shortcode. There will be 6,000 TV spots, 30,000 posters, and more than 200,000 individual birth planning cards. We also are going into 400 health facilities to train health workers on registering pregnant women for the service. We are bringing people to the telecommunications companies in this instance with a massive, massive budget. To put it just finally in some perspective, the the Ministry of Health in Tanzania is the 4th largest media buyer in the country on average for the last several years. That's in competition with Coca-Cola, with Serengeti breweries, with the tobacco companies, and with all of the telcos. They are number 4. There's a massive amount of education and advertising that the ministry is putting out there. So again, there's an opportunity for there to be a win-win and a mutually beneficial model there. So that's an idea with some revenue sharing, PPPs, and then also, again, focusing on private sector sustainability here. I think I'll move on to last point here, which is, again, with Dr. Mwendwa and Dr. Wanani in the room, as well as Mr. Abona, a key theme is on results. And I think in order for the programs to be sustainable, there needs to be the focus on the results, answering what is the public health impact from the beginning and ensuring that that is what's being delivered on. Again, this is the idea of who's across from the table. The private sector will need to understand that the focus will be on the public health, and the ministries of health will understand that this needs to be on private sector. Lastly, I'll throw out there and maybe ask Linda if we can have some dialogue about it, looking at regulators, again, looking at what is the role of the ministries and potentially groups like GSMA in helping to negotiate lower but commercially viable rates. looking at, as Mr. Abona pointed out, organizations like the Communications Access Fund that are specifically designed in order to bring and build cell tower out in the rural and underserved areas. As far as I understand in Tanzania, there has been very little utilization of those funds. So what capacity do we have within the mHealth space to put pressure on these organizations? And also to put some pressure back on the donors in two respects, not just in our siloed funding within public health, but also looking at some of our USAID and some of our broader donor relationships and looking at cross-sectoral approaches to addressing mHealth with agriculture, mobile money, and mHealth together, and starting to pool that. Because again, we're all trying to get out to that poor rural farmer, whether it's about crop rotation, whether it's about immunization and vaccines, or the importance of sending your child to school. As a global community in development, we have a lot of funds going out to that same farmer, and we could really do well by the farmer as well as our programs in order to consolidate, as well as look at pooling the resources. So again, I appreciate your time, and I look forward to the questions. Thank you.
Thank you all. You did a great job of laying out some of really important issues related to sustainability and country ownership. And the beauty of having you all here, Ministry of Health representatives, CDC, in-country representatives, and actual country manager implementers is a real bonus for those of us here. So we really appreciate your being here. I'd like to start off, though, by asking if there are any questions or comments that you have, and if you would please address any particular member of the panel that you can, that would be great. Otherwise, I'm sure we can, different panel members can respond. But are there any comments or questions? Sure.
I just want to thank you so much. It's one of the best sessions I've been to all week. So I appreciate your being here and sharing what you've done with us. Kathy, a question for you. I really enjoyed your presentation. You mentioned the short code, where there were two different short codes, one for internal communications and those for the public to provide inquiries. Could you explain the various scenarios that the public would use their short code as part of the system?
Thank you.
Kathy, speak closely to the mic, otherwise you won't.
Can you hear me? Just to give you an idea, the two short codes, the internal one is the one that's used just by the KEMSA staff. And it allows for anyone who is within the KEMSA database as a KEMSA employee to use, and all the registered mobile phones can be used but for free, at no cost. So you can, they're all registered phones within the database, and you can report, inquire, order, for free. And then there's the public short code that allows for me, the patient, inquiring into the system and finding out if the drug I need is in the facility before I can get there. We've also had a lot of issues, when it comes to integrity, where the ministers or the public health workers are questioned about where the drugs went. Because of the lack of proper coordination, you find that people keep asking these questions or complaining. We ordered for commodities, we hear they left the warehouse, but they never got to us. So you can actually track some of the deliveries. So you can inquire and find out if a facility has had a delivery in, say, the last week or so. So it allows for the public to inquire into the KEMSA system and find out if the drug you need is in the facility before you even leave your house, for example.
Yes, thank you very much. My name is Eugene. I'm from Nigeria. And I work with the National Primary Healthcare Development Agency. We are also exploring a whole lot of issues concerning implementation of mHealth. I want to really commend the presenters for sharing with us. I've actually learned a lot from that. Can I ask if there's someone from IFC here in the room? IFC, World Bank. Okay. The idea of PPPs for mHealth and just like for other issues, it's supposed to be a sustainable marriage, and we're discussing issues of sustainability here. And CDC working in Africa very well, but CDC is merely a donor. What IFC does when they get into implementing PPPs, I'm just coming from one of their programs they did in Maseru in Lesotho, and in order to ensure that there is sustainability, they help the government to shop around for partners from the private sector. Is CDC exploring the possibilities of getting the private sector to work with government when they actually pull out for sustainability? Thank you.
I would presume that is addressed to me. So the short answer is yes. And the longer version of that answer is, so this is done through the implementing partner. It's actually the implementing partner that is connecting the government to the private sector. So in country, as CDC, what we do is we support the entire process. So for example, where the implementing partner may have challenges in accessing either a section in the government or the private sector, then CDC would come in to support that. But the actual implementation is done by the implementing partner. At the end of the day, you're right. I don't know which comes after the other or before the other. It's like the chicken and the egg, but sustainability is probably an acronym to PPP. The interest in PPP from a donor perspective is actually a vehicle towards sustainability. So the interest is common. The actual implementation is done by the actual implementing partner. CDC in country supports and provides resources. I hope that answers your question.
I want to add that IFC, stay closer to the mic, that IFC basically is a partner. And in Kenya, we have the partner group. Let me call it the donor, coordinating group that they all come together. So whatever IFC does, even CDC is aware. So that is how we are working in Kenya.
Hi.
Yeah, maybe even me, I can share with you experience of Tanzania. Under sector-wide approach, this is where we work together with the different donors as well as other stakeholders. Basically, the aim is to move toward the sustaining the health service provision within our country. So I think that kind of partnership where we meet all the time, I think have created some values in our country. Thank you.
Hi, my name is Zara Hirji. I'm with FIO Corporation from Toronto. We make mobile diagnostic devices for infectious diseases in developing countries. Thank you, first of all, for your presentations. They were really wonderful. We are working in Kenya, so I had a few questions. The first one is just a simple question for Kathy. What was the name of the company that developed the supply chain system for KEMSA? And then for the larger group, I just wanted to know about the HMIS system and if most of the mobile health programs feed the data into the HMIS, or do they have their own separate databases to do monitoring and evaluation of the project, for the projects?
The name of the developer was FinTech, and actually what was interesting is that FinTech was a mobile developer, but in the finance, in finance. What we liked about them is that they really understood the confidentiality and the privacy and security aspect, considering they have to work with banks, and not just in Kenya, but in a few other countries in Africa. So, and we came to realize, when you're developing a mobile application is a mobile application, whether it's being used in banking or healthcare. The most important thing was getting to understand that these people were going to provide a secure system, and they convinced us. And so that's the name of the company that we used.
I will attempt to answer part of the second question. And if I understood it right, I think it goes beyond mHealth. So the general setup of data systems in health in Kenya is that, first of all, health facilities have their own individual or patient-level data. And it could be either manual or electronic through EMRs or EHRs. And then in Kenya, we use DHIS, which is a software for aggregating clinic-level data. So what happens is the facilities go through the governmental structures to the district and then to the province, and the aggregated data is entered into this system, which is in the central government HIS division. That is how the structure is. So, and the system had to be customized according to the government M&E tools or reporting tools at all those levels. I hope that partially answers the question, if I understood it right.
Yeah. As James has rightfully said, in Kenya now we are looking at how we can integrate all the information systems. And we are now working on what we call the interoperability, process. And one of the things we are looking at is the unique identifier, personal unique identifier, which has a lot of policy implications, but we are working at that, and we are in a lot of discussions. Again, I thank CDC Foundation for actually, and CDC Kenya for supporting this process. So we hope that once, we are in agreement, then even all the silos will be linked. Thank you. I hope that answers your question.
Thank you very much.
Yeah.
Sorry, just briefly, again, because we're here and discussing our actual experiences in country, I think it's a really important question that you're raising, and again, would love to encourage the donor community, implementing partners, really to collaborate. And I think the Tanzanian government has done a fantastic job in organizing, leading a community of practice that has enabled very transparent and collaborative environment where different organizations can come together. An example of this, to your point around disease surveillance, but then linking in with monitoring and evaluation, that's actually exactly what's happened with the ministry's leadership. Epidemiology now is working directly with HMIS in order to link that epidemiological data directly into the DHIS2, as well as the National Malaria Control Program. The President's Malaria Initiative came forward and said, there's been this successful project in Zanzibar with malaria-specific tracking. We'd love to bring that to mainland. And I have to be honest, a lot of these partnerships, bringing malaria, epidemiology, HMIS, but bringing us all together and saying, what is the standard case definition of malaria? Guess what? They're not the same. Not even at WHO, they're not the same between IDSR, disease surveillance, and malaria. But again, it can be done. I would say it took more than a year, about 14 months. But again, now at least we have the initial 3 parts. So next, maybe tuberculosis, and so on and so on. So again, I think it's an excellent point. And with the leadership, potentially everyone aiming towards the monitoring and evaluation and one key data standard, I do think that there's a lot of opportunity to increase sustainability.
Thanks. We have time for one more question, so it's perfect. Go ahead.
My name is Andrew Carlin. I'm a researcher with Population Council here in Washington, D.C. And I do appreciate, as others have said, the breadth of the conversation, the examples given, and it's a great way to learn about how PPP has been applied. It seems to me, though, there's one key ingredient in these examples, and that's Safaricom. And so when there is not a partner such as Safaricom in other places, I mean, what can we take from these examples about how you engage private sector and bring them to the table, and how government can lead that process, of course. And it's public-private partnership is not just about contracting, and it's not just about CSR. Right? And we've seen problems, of course, with CSR. It tends to fall down, and it tends to be proprietary. So we're working in a mature, diverse market where you have multiple telecoms and providers. That's a huge difficulty, and getting out of the starting blocks, even for government, is very difficult. Nigeria is a great example of that, despite the gains they've had in collaboration. And the question then leads to, well, what other models of PPP are we looking at? For instance, the example you just gave around providing data that then can be looked at by different parties. Similar to what we've seen around whether it's satellite meteorological data around crop predictions and so on. When that data are standardized and out there and private sector innovators can look at that and use that, we'll see the type of short cycle learning and innovation that really does drive, and that we've seen really in East Africa that's been really beneficial. So moving towards that, and key things such as that, the unique ID, of course, is one, but there's a whole set of standardizations, of data access, of making that available in a way. And so I'd like to hear a bit more about what you see about that potential as well, which brings a new wrinkle to PPP.
Yeah, maybe I'll briefly start. I want to give time for the other panelists because, in fact, we're actually not working directly with only one telecommunications company because of the geography in Tanzania and the coverage. Though I said it is the best infrastructure there, the cellular networks do not have universal coverage, and no network alone has universal coverage. So we've needed to work across carriers, and we've really only worked on solutions on a national scale that are cross-carrier. It's a necessity. They have to be network agnostic, as we say. I think your point is very well taken, and one approach that we actually have a communications partner specifically who helps us do business analysis, actually write business cases, do revenue generation models, try to do predictive analytics on where we see these programs going, and that's specifically so that when we go to the private sector from the beginning, we can actually have a conversation with them about what they're interested in. I will regularly go to private sector and ask them, how are you going to make money in this? Where is your revenue coming from? Are you trying to increase your subscribers? Is this a service offering? Just so that we can have that kind of conversation and understand what these opportunities are. But I think to your point, there are a lot of options in share of voice, in again, many different models there that need to be explored in more detail. And I think a key step is in the government's willingness to work with the private sector and allow for private sector involvement and potentially providing services on behalf of the government.
Can I add a bit here quickly? One of the things Kenya has achieved is bringing the private sector on board. And because of that, we have established what we call Public-Private Partnership Health Kenya. And in this group, the government is there, finance is there, the private sector are represented, and we are discussing critical issues, about health using PPP, concept. And I think another critical thing is that in Kenya, the private sector, they have formed, sort of a group, what we call KEPSA. So it brings together the public sector, the private, everybody sitting together and discussing some of these issues. But I think you have very useful point. And you remember when I was talking, I said we have also come to learn and pick some of the useful ideas. So thank you very much.
We do need to be quick because I don't want to interfere with the keynote at 9. So yes.
Okay, I'm just going to give a quick one. My name is Okoye Obiora. With the Association of American Medical Colleges. Well, I believe education and training is key to strengthening of health systems, and the mobile health is actually going to revolutionize healthcare in Africa. So I'm just wondering, in terms of review of curriculum, in training of future healthcare professionals, because in the next 5-10 years that they want to be taking the lead. Just if you could clear up, maybe if there's partnership between the Ministry of Education and Health in making sure that some of those issues are addressed. Thank you.
Good morning. Just one comment, which I hope might summarize or perhaps answer some of the questions that have been raised about both sustainability and about the role of public-private sector partnerships. I'm Chloe Taney. I'm the Senior Vice President for External Affairs at the CDC Foundation in Atlanta, and I want to first of all, of course, commend our terrific presenters and implementers. It is a privilege to work with them, but also just to say we are actively, our role, we were legislated into existence by Congress 17 years ago to do exactly what we're talking about this morning, and that is to bring the private and the philanthropic sectors into partnership with the government. And that is not just here, but around the world and over 60 countries where CDC is working. The programs that you've heard about this morning are absolutely vital for CDC for helping to achieve its global health mission and its public health mission in these countries, working in tandem with the ministries. So, again, if there are ways that you may be interested in helping, if there are connections that you might help us make, we work, as I said, in over 60 countries, and we currently manage over 200 active programs with and for CDC around the world. So, again, thank you for what all of you are doing. It is mind-boggling to be here and hear all about it. So, thanks for being in the mix with us.